Hi, good afternoon. My name is Akram Shayeb, and it's a pleasure to speak today and present some of the results of my research project, which is on Cabozantinib Safety with different anticoagulants in patients with renal cell carcinoma. And my mentor is Dr. Anna McKay. So renal cell carcinoma accounts for 400,000 new cases and 170,000 deaths annually worldwide. In the United States, it's estimated that 79,000 new cases and 13,900 deaths will be in 2022. One of the complications of renal cell carcinoma or patients with cancer is development of thrombosis. So in patients with renal cell carcinoma, there is 1.3 to 5.3-fold higher risk of venous thrombosis than cancers with low BTE risk. And BTE is the second leading cause of death in patients with cancer. So it's an important topic to address in these patients to minimize morbidity and mortality. But not everyone develops thrombosis, and there's a lot of risk factors that account for some patients developing more thrombosis than others. And one of this is the drug therapy that the patients get. In patients with renal cell carcinoma, one of the drugs that we provide is Cabozantinib, short for Cabo for the rest of the talk. Cabozantinib is a multi-targeted tyrosine kinase inhibitor affecting different receptors, the vascular endothelial growth factor receptor, hepatocyte growth factor receptor, and growth arrest specific protein 6 receptor. These receptors are in the cancer cells as well as in the blood vessel. And these are important for angiogenesis, which is the blood supply to the cancer, progression of the tumor cells, and tumor cell survival. These receptors are overexpressed in RCC, and that is how cabozantinib mechanism of action works in this particular population. We know from randomized prospective controlled trials, including the Cabozan and the Meteor trial, that Cabo has improved survival in patients with advanced RCC, both in the first and second line therapy. And the diagram on the right shows the location of some of the receptors in the tumor cell versus the blood cell. The blood vessel. So what are some gap of knowledges for taking care of these patients that are on Cabozantinib and the management of thrombosis? One, Cabo is associated with 3% bleeding and 9% thrombosis toxicities in clinical trials. Number two, outside of clinical trials, Cabo bleeding and thrombosis safety profile is unknown. There is limited safety data of concomitant Cabo use with different anticoagulants, specifically direct oral anticoagulants. And this is important because for more than a decade, low molecular weight heparin has been the standard of care for thrombosis treatment in patients with cancer. However, in 2022, there has been multiple clinical trials that have shown that DOACs are better than low molecular weight heparin. These include Hokusai trial, Select trial, Adams BDE trial, and the Caravaggio trial. So according to the National Cancer Center Network guidelines, it is category 1 to provide a DOAC over a low molecular weight heparin for the treatment of thrombosis in patients with cancer. The only exception would be gastrointestinal cancer, specifically stomach, which tend to have more bleeding complications. In addition, clinical trials that led to Cabo approval excluded patients receiving DOACs and allowed only low molecular weight heparin utilization. And this is one of the drives of our research, because a lot of patients were excluded as part of the screening process if they were on a DOAC from clinical trial participation. So a major gap was there's no safety data to guide clinicians on the utilization of Cabo with concurrent DOACs. So our aim was to study the hemostatic safety profile of cabozantinib and concurrent use of different anticoagulants, DOACs, and low molecular weight heparin in patients with advanced or metastatic RCC through a real-world multicenter cohort. The question was, in adults older than 18 years of age with advanced or metastatic RCC who are treated with cabozantinib in the United States, what is the safety and efficacy of DOACs compared with low molecular weight heparin? And I define here advanced or metastatic because that is the FDA indication for cabozantinib. So we conducted a retrospective multi-center study across 9 sites in the United States, and these are the sites listed here. The inclusion criteria basically was any adult over the age of 18 who had advanced RCC and was receiving treatment with cabozantinib since April 1st, 2016. We utilized this date because that in April of 2016 was the FDA approval for cabozantinib for RCC treatment in the United States. Anticoagulation could be for the treatment of thrombosis or stroke prevention for AFib. This is the study schema. This is the target population. As I mentioned, patients had to have advanced RCC or any line of Cabo. Advanced RCC, these are some terms at the bottom of the slide. Basically, patients had to have a confirmation of the diagnosis by a biopsy, and they also had to have imaging proving that they had advanced RCC, meaning metastasis. Patients were divided in 4 different categories: DOACs, low molecular weight heparin, no anticoagulant, and warfarin. Our primary endpoint was the proportion of major bleeding event incidence per the ISTH criteria. ISTH is short for the International Society of Thrombosis and Hemostasis. They have established a specific criteria for all clinical trials that involve anticoagulants to determine what is the safety outcomes in these trials. At the bottom of the slide is a summary of these criteria. Basically, in general terms, it's bleeding that is fatal, bleeding in a critical organ, such as in the brain or in the spine, bleeding that leads to transfusion of 2 units of blood or a 2-gram drop of hemoglobin. Those are some examples of major bleeding events per the ISTH criteria. Our secondary endpoint, which was more exploratory, was a proportion of new or recurrent thrombosis while on anticoagulation. BTE could be any DVT, deep venous thrombosis, mainly in the extremities, legs, arms. It could be a pulmonary embolism, or it could be a visceral thrombosis. All thrombosis had to be confirmed by imaging studies, depending on the type of thrombosis. We had 298 patients recruited into the study. These are the statistics. For the primary and secondary outcomes, we use proportions. For group comparison analysis for primary and secondary outcome, we use Fisher exact test, and if there was a difference that was noted, we did pairwise comparisons. And we did some exploratory analysis for overall survival between individuals with and without BTE using Kaplan-Meier method. This is the outline of the results into 5 different categories: the baseline characteristics, cabozantinib therapy, safety outcome, which was our primary endpoint, and efficacy outcomes and survival data. For baseline characteristics, this is the table. And I'm going to focus on the most important items here. So in terms of demographics, the median age at diagnosis of metastasis was 62 years, which is consistent with what we observed with renal cell carcinoma in the general population. Most patients were male, which is also consistent with what we observe in the general population with RCC. The majority of patients were white, and which was disproportionately different from other ethnic groups, but this still should not be a confounding in terms of bleeding complications for anticoagulant. In addition, half of them were smokers, as evidenced by the pink bar. In terms of cancer characteristics at presentation, most patients had clear cell histology predominance. About 76% had a nephrectomy. Stage 4 at diagnosis was about 60%, but as I mentioned, all of these patients eventually developed metastasis, and they were stage 4, and that's why the indication for cabozantinib is. The most common site of metastasis was pulmonary metastasis, followed by bone metastasis. And we use a risk stratification group which is for renal cell carcinoma. And we divide the patients based on this score into favorable and intermediate and poor together. So if they're intermediate and poor, we treat them in a certain way, and if they're good, we treat them in a certain way. And about 80% were intermediate to poor risk. And this basically baseline characteristics highlight that this cohort is representative of what we would observe with RCC and validating that this cohort is generalizable to what we see in real practice. In terms of cabozantinib therapy, cabozantinib treatment line was in naive, meaning that they haven't received any other type of medications or drugs, in 19.8%. Second line, meaning that they received at least one other medication before cabozantinib, was in 34.9%. And third line or more was in 45.3%. We did time to treatment failure. This is kind of a validation step of the cohort. And what that means is in oncology trials, we looked at when the patient got the cabozantinib drug until they failed the drug. And by failure, what I mean is the patient had progression, objectively evidenced in the imaging studies. They have intolerance to toxicities, or they died. And the time to treatment failure for first line cabozantinib was 8.4 months. For second line was 7.9 months. And for third line or more was 8.5 months. And this is important because in the Cabozant trial, which was for first line, and the Meteor trial was for second line, they showed similar numbers for first and second line drugs, which is consistent with prospective studies. Now, safety outcome, which was our primary endpoint, 8 patients had a major bleeding event. The most common bleeding site was gastrointestinal. Cabozantinib was discontinued in 4 out of 8 patients. And in each of these columns, it showed one of the criteria for the ISTH major bleeding criteria for anticoagulants. And all patients met one of these criteria. Major bleeding events in patients with advanced RCC on cabozantinib with and without different anticoagulants. This is the table which shows the proportion of bleeding events depending on the group. And there was no overall difference of major bleeding proportions between the 4-group comparison of no anticoagulant, low molecular weight heparin, DOAC, and warfarin. Now, the warfarin group is small, and probably we can't make any conclusions from that group. I rerun the analysis on the 3 groups without the warfarin, and it was still not statistically significant. I included the warfarin for sake of completion, but as I mentioned earlier, the standard of care in 2022 is DOAC, and if the patient is not a candidate for DOAC, they should be on low molecular weight heparin, which is superior to warfarin. So for patients with cancer, warfarin is really in disuse, and there's very few exceptions that the drug should be used. The efficacy outcome, so this is the BTI outcomes in patients with advanced RCC on cabozantinib. In this column, it shows that the number of patients on anticoagulation not for thrombosis. And in this column, it shows the patients who had total BTE, meaning that they had an anticoagulant for a thrombosis indication. And in the last column, it shows the recurrent or new BTE while on anticoagulation. And there was no difference in the proportion of new or recurrent BTE among the different anticoagulant groups, low molecular weight heparin, DOAC, and warfarin. When we excluded warfarin, again, the conclusion remains the same. Lastly, we did a survival data. This is the Kaplan-Meier survival curve among patients with RCC and BTE. And patients without a BTE had a statistically significant better survival than patients with a BTE, with a p-value of 0.02. And patients with a BTE had a hazard ratio of 1.48, which was statistically significant compared with those without a BTE. Some of the limitations of the study. So this is a retrospective study design, and there's a lot of limitations that come with this type of design. So in order to minimize those limitations, no patients were excluded to equal chance of selection and avoid non-representation. Controls were not recruited by continuous sampling to avoid selection bias. There was a coding manual of each variable had a predefined and precise values for each site when they were collecting the data to avoid misclassification. Bleeding events require hospitalization to avoid recall. If you the major bleeding events per ISTH criteria, as I mentioned, they're fatal, bleeding in critical organs. Those are all likely to be treated in inpatient. What we did not capture was the clinically relevant non-major bleeding events And there is a definition under ISTH for this category. And basically, it's any patient that does not meet major bleeding event category, meaning, for example, a patient who had a nosebleed or a gingival bleed that calls for the physician office, that would be considered a non-major bleeding event. But these non-major bleeding events are unlikely to change anticoagulation management or recommendations in clinical practice. But it is a limitation, and we acknowledge it. So in conclusion, this cohort provides generalizable and first real-world data on bleeding and thrombosis complications in patients with RCC. One of the strengths is that the cohort represents the characteristics of patients with RCC that we see in real-world data. The time to treatment failure is consistent with prospective studies. Those are all strengths and representation of the cohort. No overall difference of major bleeding or recurrent new BTE events between low molecular weight heparin and DOAC. And patients with RCC who had a BTE had a worse overall survival than those without a BTE. So what are the implications of these findings? DOACs are safe and effective as an anticoagulant therapy in patients with RCC who are using Cabozantinib. Some future directions that I will plan to use this cohort for is perhaps create a predictive model from the time of diagnosis to the time of thrombosis, and subsequently validate this prediction model using an external cohort. We have some cohorts in the cancer center that are being collected prospectively that could be utilized for this. I want to acknowledge my mentor, Dr. Rana McKay, all our collaborators who helped make this happen from the many institutions that are listed here, the MASS program for allowing me to present my results, and Dr. Coamo and Mercedo for all their support and advice during both seminars. And I will take any questions. And these are my references.